Welcome to our first video on water-soluble vitamins. Let's begin. In this lecture, we'll cover vitamin B1, B2, B3, and B5. We'll cover the rest in the next lecture. Let's begin with the first one, vitamin B1. Let's start with some general information. Vitamin B1 is also known as thiamine. It can be found in yeast, legumes, brown rice, and whole grains. Now let's move on to the risk factors for thiamine deficiency. Vitamin B1 deficiency is common in people with decreased dietary intake. Some examples in this category are starvation, anorexia, and excessive alcohol consumption. Alcohol consumption can contribute to thiamine deficiency in multiple ways. First, people who consume large amounts of alcohol typically have poor dietary habits as well, which can lead to thiamine deficiency. Additionally, excessive amounts of alcohol can lead to an inflammatory state in the GI tract that can impair thiamine absorption. Thiamine deficiency can also occur in some disorders impeding duodenal absorption, such as in Crohn's disease or after gastrointestinal surgery. Conditions where the vitamin B1 requirements are increased, such as hyperthyroidism or febrile illness, can also lead to thiamine deficiency. Finally, increased loss of thiamine in patients, such as in patients on hemodialysis or taking loop diuretics, can also cause thiamine deficiency as well. Let's move forward with clinical presentation. First, let's start with Wernicke's encephalopathy, which is acute and reversible condition that occurs secondary to thiamine deficiency. The classic triad includes confusion, oculomotor symptoms such as diplopia, conjugate gaze palsy, or nystagmus, and gait disturbances. Korsakoff syndrome, in contrast, is a chronic and irreversible condition that occurs secondary to thiamine deficiency. It presents with impairment of short-term memory and gaps in long-term memory. Therefore, patients usually have difficulty remembering new information and recent events, but they can remember events before the episode with some gaps. Because patients cannot remember certain details when asked, they make up events to fill those gaps. This is known as confabulation. Patients with confabulation may truly believe the stories that they tell in order to fill in memory gaps, and the stories may seem believable, so it is important to corroborate their stories to know if they're telling the truth or not. Patients may also present with some personality changes such as apathy or listlessness. Finally, Wernicke-Korsakoff syndrome is the combination of both of the syndromes we just mentioned. Other conditions caused by vitamin B1 deficiency are dry and wet beriberi. Dry beriberi presents with symmetrical peripheral neuropathy accompanied by sensory and motor impairments. It may also present with muscle wasting and paralysis. Wet beriberi, in contrast, presents with peripheral vasodilation and a high cardiac output state. As the disease progresses, the heart goes into remodeling, leading to a high output heart failure and edema. A 65-year-old man is brought to the physician by his daughter due to confusion, double vision, and memory problems. His daughter says that although he was a sweet father, he became rude and socially unrestricted. Additionally, he often makes up stories that never happened. The physical exam reveals a wide-based gait with small steps. What is the most likely diagnosis and underlying cause? This patient presents with confusion and double vision, also known as diplopia. The physical exam reveals wide-based gait and small steps, suggesting ataxia. Confusion, diplopia, and ataxia are classic signs of Wernicke's encephalopathy. He also has memory problems, and he often makes up stories that never happened. This latter phenomenon is known as confabulation. Although the patient was a sweet father, he became rude and socially unrestricted. Memory problems, confabulations, and personality changes are characteristic of Korsakoff syndrome. Therefore, this patient has Wernicke-Korsakoff syndrome. Wernicke-Korsakoff syndrome is caused by vitamin B1 deficiency and is most commonly associated with chronic alcoholism. The diagnosis of vitamin B1 deficiency is primarily clinical, based on the patient's history and physical exam. Regarding the patient's history, it's essential to recognize the risk in patients with malnutrition, such as those with a history of alcohol abuse, GI surgery, or starvation. On physical exam, altered consciousness may be found, accompanied by ophthalmoplegia and ataxia if the patient has Wernicke encephalopathy. Patients with dry beriberi may have peripheral neuropathy on physical exam, and those with wet beriberi may have signs of heart failure such as edema. While it may be mentioned on your exams, a red blood cell transketolase test is rarely performed clinically today in favor of direct measurement of thiamine concentration. However, if measured, the red blood cell transketolase will initially be low in patients with thiamine deficiency and will increase after vitamin B1 administration. Wernicke encephalopathy can also be seen on an MRI as bilateral, symmetrical hyperintensities of the medial thalami. This image shows a cranial MRI of a patient with Wernicke's encephalopathy. Notice that the MRI is showing hyperintensities in the medial portion of the thalamus. Now let's cover treatment. The treatment for vitamin B1 deficiency is simple. One needs to replace vitamin B1. However, when treating vitamin B1 deficiency, it's important to recognize patients with a history of alcoholism or malnutrition. This is because in these patients, thiamine must be administered before glucose, because if glucose is administered before thiamine, it may precipitate the acute onset of Wernicke's encephalopathy. Now that we're done with vitamin B1, let's continue with vitamin B2. Vitamin B2 is also known as riboflavin. It can be found in milk, eggs, meat, fish, and green vegetables. Vitamin B2 deficiency is common in patients who are alcohol users, patients with malnutrition, and those with restrictive diets that avoid dairy, such as vegan or lactose-free diets, since dairy is a great source of vitamin B2. Vitamin B2 deficiency can present with chylosis, which is inflammation of the corners of the mouth that can lead to fissuring and pain. Patients can also present with corneal vascularization, which manifests as red, itchy eyes, normocytic anemia, and seborrheic dermatitis. This image is showing angular chylosis in a patient with riboflavin deficiency. Angular chylitis is an inflammation of the corners of the mouth and is often painful. Here we see corneal neovascularization, another clinical finding of riboflavin deficiency. It presents as fine and superficial neovascularization, as you can see in the picture. It may present with mild vision loss and red, itchy eyes. As in most vitamin deficiencies, the diagnosis is mainly clinical, taking into account the patient's history and physical exam, especially in those at risk for deficiency. To treat riboflavin deficiency, appropriate vitamin replacement is needed, just like with the other vitamin deficiencies in this lecture. Let's move forward with the next vitamin of the vitamin B complex, vitamin B3. Let's start with some general information about vitamin B3. Vitamin B3 is also known as niacin and can be found in liver, legumes, and seeds. Niacin can be used in the treatment of dyslipidemia as it lowers VLDL and increases HDL. Let's move on to risk factors. Patients who are prone to have a lack of vitamin B3 include alcohol users due to malnutrition, those with prolonged use of isoniazid, and those with carcinoid syndrome or Hartnup disease. Let's take a closer look at some of these. Prolonged isoniazid use can lead to a vitamin B6 deficiency. Since vitamin B6 is required for the production of vitamin B3, this can lead to a B3 deficiency. Tryptophan is also an essential element in the formation of vitamin B3. Therefore, conditions like carcinoid syndrome and Hartnup syndrome, which are associated with tryptophan deficiency, can ultimately lead to a vitamin B3 deficiency. Let's examine these relationships on the next slide. Tryptophan with vitamins B6 and B2 forms niacin, which is a component of NAD/NADP. Remember that isoniazid, a drug used in the treatment of tuberculosis, can cause vitamin B6 deficiency. Therefore, you can see in this image, if there is a depletion of vitamin B6, we cannot form niacin, causing its deficiency. Tryptophan also is an essential component in the formation of serotonin and melatonin. This pathway can help us explain how carcinoid syndrome may lead to niacin deficiency. In carcinoid syndrome, tumor cells produce excess amounts of serotonin. Since tryptophan is being preferentially used to create serotonin, it leads to a decrease in the amount of niacin produced. Now let's cover the clinical presentation. When a patient has niacin deficiency, a clinical condition known as pellagra can occur. It presents with a classic triad of the 3 Ds: dermatitis in sun-exposed areas, diarrhea, and dementia. Since niacin may be given as a medication to treat dyslipidemia, one may also see the effects of niacin toxicity. High doses of niacin can cause prostaglandin-induced flushing, which can be relieved by aspirin. It can also cause some metabolic abnormalities, such as hyperglycemia and hyperuricemia. Because niacin decreases uric acid excretion, it can lead to podagra, and therefore should be avoided in patients with gout. As with other vitamin deficiencies we have discussed, the diagnosis is mainly clinical, and patients with niacin deficiency can be treated with vitamin replacement. This image shows the classic dermatitis found in pellagra, a disease caused by vitamin B3 deficiency. As you can see in the picture, dermatitis is localized in sun-exposed areas like the neck and arms. A 37-year-old woman comes to the physician reporting skin rash and watery diarrhea for 3 months. She also has difficulty remembering the names of her family members. She has been taking medications for primary active tuberculosis for 5 months. The physical exam reveals macules and vesicles on the neck and hands. What is the most likely underlying cause of this patient's current complaints? This woman reports skin rash and watery diarrhea. Physical exam reveals macules and vesicles on the neck and hands. She also has difficulty remembering the names of her family members. Dermatitis, diarrhea, and dementia-like symptoms raise a strong suspicion for pellagra, a disease caused by vitamin B3 deficiency. This patient has been taking medications for primary active tuberculosis for 5 months. One of the anti-tuberculosis medications included in primary treatment is isoniazid. Isoniazid causes vitamin B6 deficiency. Vitamin B6, in turn, is necessary for the biochemical conversion of tryptophan into vitamin B3, also known as niacin. Therefore, isoniazid-induced vitamin B6 deficiency led to vitamin B3 deficiency and pellagra in this patient. Alright, now that we've finished vitamin B3, let's move to vitamin B5. Vitamin B5 is also known as pantothenic acid. It can be found in egg yolk, liver, kidney, broccoli, and milk. The deficiency of pantothenic acid is extremely rare and only occurs in severely malnourished patients. When vitamin B5 is deficient, paresthesias, dermatitis, enteritis, alopecia, and adrenal insufficiency can occur. Similar to other vitamin deficiencies, the diagnosis is made by the characteristic clinical features and risk factors. The treatment is focused on vitamin replacement. A 45-year-old man comes to the physician due to watery diarrhea and skin rash for 3 months. He also has difficulty remembering his home address and the names of his children. His past medical history is significant for chronic alcoholism. Physical exam reveals a malnourished man with hyperpigmented skin and maculovesicular rash on the neck and hands. What is the most likely diagnosis in this patient? This patient presents with watery diarrhea and skin rash for 3 months. Physical exam reveals a malnourished man with hyperpigmented skin and maculovesicular rash on the neck and hands. He also has difficulty remembering his home address and names of his children. Diarrhea, dermatitis, and dementia-like symptoms suggest the diagnosis of pellagra due to vitamin B3 deficiency. Pellagra is even more likely given his chronic alcoholism because alcoholics are prone to malabsorption and vitamin deficiencies. A 55-year-old woman comes to the physician due to blurred vision for the past 4 months. She is on a vegan and lactose-free diet. Her vital signs include a temperature of 36 degrees Celsius, a blood pressure of 135/80, a heart rate of 89, and respiratory rate of 14. Physical exam reveals red linear sores at the angles of her mouth. Ophthalmologic exam is significant for blood vessel formation on the cornea. The lens and retina are normal. Deficiency of which of the following vitamins most likely accounts for this patient's presentation? A. Pantothenic acid, B. Thiamine, C. Niacin, or D. Riboflavin. This 55-year-old woman complains of blurred vision for 4 months. She's on a vegan and lactose-free diet that can predispose her to various nutritional deficiencies unless she receives vitamin supplements. Physical exam reveals red linear sores at the angles of her mouth. This finding is known as angular cheilitis. Ophthalmologic exam is significant for blood vessel formation on the cornea, the finding known as corneal neovascularization. Her lens and retina are normal, making cataracts and retinal diseases a less likely cause of her blurred vision. Angular cheilitis and corneal neovascularization are classic findings of vitamin B2 deficiency, also known as riboflavin deficiency. Therefore, correct answer is option D. Again, here is a slide reminding us of the clinical presentation of vitamin B2 deficiency. Pause the video and take a moment to consider this slide once more. Let's discuss why other options are incorrect. Option A is incorrect because pantothenic acid deficiency is rare and presents with alopecia, enteritis, dermatitis, and adrenal insufficiency. Option B is incorrect because thiamine deficiency results in beriberi or Wernicke-Korsakoff syndrome. This patient has no symptoms of either of those conditions. Finally, option C is incorrect because niacin deficiency presents as pellagra with diarrhea, dermatitis, and dementia. And that concludes our lecture on water-soluble vitamins B1, B2, B3, and B5.